Thank you all for joining us today. My name is Jeff Laporte, and I am the Education Committee Chair for the Illinois Society for Cardiopulmonary Health and Rehabilitation, otherwise better known as ISCHR. First, I would like to thank my committee members, Leanne Raiders and Jamal Ozimek, for their help in putting this together as our first non-traditional education session, where we focus more on networking and seeing what other clinics are actually doing for cardiac rehab. The format for the panel will be as follows. A pre-assigned question is asked by our moderator to two of our panelists. If another panelist wants to add something that's different after two panelists have answered a question, they may. However, keep in mind we do not want to be too long on one question, and we want to try and keep the session under 60 minutes. And now I'd like to introduce our panelists and our moderator for this morning. First, we have Jim Baumgartner, Bachelor's of Science from University of Buffalo in Exercise Science with concentration in Sports Medicine, Master of Science from University of Illinois Chicago in Exercise Physiology, is an ACSM clinical exercise physiologist involved in the field of cardiopulmonary rehabilitation for the past 22 years. He currently is the manager of cardiopulmonary rehabilitation at Franciscan Health Olympia Fields, previously manager of cardiopulmonary rehab at the University of Chicago Medical Center and Elmhurst Hospital. Special interest is exercise for the management of CHF, and is coordinated exercise arm for the heart failure action trial at the University of Chicago. Next, we have Rudia Szymanski. Graduated from Purdue University with a Bachelor of Science and Nursing degree and a nurse practitioner focus. She has worked in the cardiac rehabilitation field for at least 20 of her 30 plus years as a registered nurse. Professional experience ranges from intensive care, bedside nursing, to administrative house coverage as clinical nurse educator and also information systems specialist for the electronic medical record, also known as EMR. And quality improvement project leader, generally with a focus in cardiovascular care. Currently, she is clinical coordinator for an active outpatient cardiac rehabilitation department, and she's over 100 plus patients a day for a nationally top-ranked academic medical center. She's responsible for all aspects of operation for this department. She also currently acts as reimbursement chair of the board of directors for ISCHR and has been a previous past president of ISCHR. Actively affiliated with AAZVPR, currently serves as a member of the Medicare Administrative Contractor, also better known as MAC, resource group, traveling to Washington, D.C. annually to lobby for cardiac rehab issues with House and Senate. And also current vice president of Mended Hearts Chapter 106, a national group that supports and educates individual effects by heart disease, and has also published work in cardiac rehabilitation in Women, Chapter 7. During time away from office, Rita enjoys golf, concerts, and spectating at various NFL and MLB stadiums. Next panelist is Eric Ostrowski, who is a master's prepared exercise physiologist who has been working in the cardiac and pulmonary rehabilitation field since early 2013. He is an ACSM registered clinical exercise physiologist and holds a certified cardiac rehab professional credential through AACVPR. He started his career in Southern Illinois. Go Salukis. Did I say that right, Eric?
Salukis.
Salukis. Okay. But has recently relocated to Tulsa, Oklahoma, area where he successfully opened up and manages a cardiac rehab program. He also is our communications chair for the ISCHR board of directors and oversees the development and maintenance of the organization's website and marketing. Next panelist is Barb Masters, who is our current president of the ISCHR, appointed a fellow of AACVPR in 2016, has been in cardiac rehab for 25 years, pulmonary rehab 3 years when she became the coordinator of both as assistant nurse manager in cardiac pulmonary rehabilitation at Memorial Hospital in Belleville. She has a master's in nursing in BC and cardiovascular nurse for 14 years, is CCRP for 2 years, and also I know for a fact, Barbara, you co-authored in the Journal of Cardiopulmonary Rehabilitation Prevention in 2011 titled Recommendations for Managing Patients with Diabetes, Mellitus, and Cardiopulmonary Rehabilitation, an American Association of Cardiovascular and Pulmonary Rehabilitation Statement. My go-to for all my diabetes credential or knowledge. Leanne Raiders is a cardiopulmonary nurse at FHN and Education Committee member for ISCHR. She has been a cardiac nurse for over 12 years and 3 years in pulmonary rehab. Myself, current Education Committee Chair, Jeff Laporte for ISCHR, Bachelor's of Exercise and Health Science from Alma College, and a Master's of Clinical Exercise Physiology from Benedictine University. Also ACSM, RCEP certified, and NSCA certified strength conditioning specialist. Exercise physiologist and internship coordinator for cardiopulmonary rehab department at Mercy Chicago Hospital and Medical Center. And lastly, our moderator, Dr. Jamal Ozamek. And Jamal, I apologize if I butchered your last name.
Nope, that was correct.
All right, great. So Dr. Jamal is a clinical assistant professor and director of the University of Illinois at Chicago Cardiac Rehabilitation Program. He received a bachelor's in exercise biology from the University of California, Davis, a master's in health and exercise science from Wake Forest University, and a PhD from the Human Performance Lab at Ball State University in clinical exercise physiology, and completed his postdoctoral research fellowship at the University of Colorado Anschutz Medical Campus. He has 7 years cardiac rehab experience. So thank you all for joining with us for the special event, and I will give the reins over to Jamal to start moderating for this.
Thank you very much, Jeff, for that great introduction. Today we're going to divide our questions into 5 different sections. The first one will be all phases of cardiac rehab. The next related to PAD programming. And then we'll go into phase 1, phase 2, and if time allows, phase 3 cardiac rehab. So my first question is directed to Barbara and Rita. What are ways in which your department has forged a multidisciplinary approach to patient care?
In many ways, we have gone to the multidisciplinary approach because we lack educators in dietary and psychiatric for depression. So in the past 2 years, I have also developed a program with our mental health attachment. So I have now a clinical social worker that can come into my department itself and do depression and coping strategies. I have a dietitian that I've been very fortunate to do that can do dietary assessment. I have a pharmacist I can count on to continue with medication approaches. But more importantly, I've gone with also my staff. Since we are cardiac pulmonary, I allow all my staff to be cross-trained, ACLS trained, so I have RNs, EPs, and respiratory therapists on my team.
So I'm very fortunate as well in the fact that we do have a registered dietitian that meets with each phase 2 patient at least once, and more so if follow-up is requested. In regards to, I have only cardiac rehab, I do not have pulmonary. So we also have to have an MD in the department because we are located slightly remote from the main hospital campus. And the MD actually has taken over all of the education sessions, which is great for us. We let them know what we want them to teach. And, you know, it's almost like the patients get a little consultation with the doctor every day if they want. Of course, they're always there for any questions that patients might have. But several years ago, I did have a couple of my nurses reorganized from my department, and I received sort of a EP in their place. So we still have the doctor, RNs, and EPs as the phase 2 practice staff. Low FTE numbers for high volume department, but I'm sure that's not unusual to anyone, but we do have great, my manager is especially supportive of a multidisciplinary approach. She understands that with all these lifestyle benefits, we have to refer out for specific psychological or behavioral lifestyle support, but we do include those things in our rotating education schedule as well.
Those are excellent ways. I think we can all appreciate the benefit of utilizing this multidisciplinary approach. The next question will be for Jim and Eric. So when expanding your programs, for example, the size of the facility or increasing the number of exercise equipment available, what were some key points you made to the administration to support funding for the project?
Yeah, I'll start with this one. This is Jim. Okay, so I've gone through this several times, and the number one thing I bring up is that as far as cost effectiveness of interventions for cardiovascular disease, cardiac rehab is one of the cheapest, being beaten only by smoking cessation programs. So I do point that out, that we're getting a huge bang for our buck by investing in cardiac rehab. The other is that I bring up some of the, really the benefits of cardiac rehab and focus on the fact that mortality is reduced by about 25 to 60%. We see a significant decrease in hospital readmissions for heart failure, MI, PCI, as well as cardiac surgery, anywhere between 25 to 36%. And then also talk about the fact that really, if a patient does go back into the hospital, that cost for rehospitalization is about 25% less than those who don't participate in cardiac rehab. So those are the things that I do focus on when bringing up the expansion of our program. It's essentially an investment that a cardiac service line has to be willing to make.
I think that's a fantastic answer. And just to piggyback off that, I mean, really my experiences when dealing with administrators is you really have to be prepared to talk about the return on investment, and that I know that administrators really like to hear when you pitch an expansion or addition of current services. So for example, if I was wanting to purchase a few treadmills for my program, I would not only bring the quotes for the treadmills, but present numerical data and financial data on, how many patients I could, expect to enroll with those additional pieces of equipment, what that cost would bring, and then also certainly the cost savings on the back end of readmission reductions as well. Like I said, additionally, administrators really love to hear that you'll be expanding or adding services. So in the previous example of trying to request treadmills, I would frame my entire pitch at this point in time for, requesting the treadmills for supervised exercise therapy for PAD patients. So I would say, cardiac rehab, we're looking to expand and add an additional patient population under the existing cardiac rehab infrastructure, just for the extremely low cost of a few treadmills. So.
That's fantastic. This next question is for Jim and Rita. Name one aspect of your program that you think makes your facility stand out compared to others, or facility or program.
Well, I'm really, really proud of our facility and the fact that we do truly try to individualize our program for each patient. We go through a very thorough assessment to ensure that, we're setting up their education plan for things that they need. The patients that are seeing the nutritionists who need to, the patients that are going to behavioral health who need to. So I think we do a really great job of individuating our program. I know it said only one thing, but the other thing I got to say is that we also really try to ensure that our department, cardiac and pulmonary rehab, is supporting both our cardiac and pulmonary service line in the sense that we really act as a mini clinic, and we really thrive on that. I got to say, I think I've got the probably the most experienced cardiac rehab nurses that I've encountered within my my current role, and we really thrive on, if a patient is having signs or symptoms, going through the process of ensuring that we're reaching out to the clinics, reaching out to the heart failure specialists, going out of our way to take care of the patient to prevent the patient from having to go to ED or getting rehospitalized.
I agree with all of those aspects. I find that sometimes I feel like there's a little competition between us and the outpatient clinic and, you know, the VAD clinic, and they're all trying to kind of do the same thing, which is something we've been doing for, you know, whatever, 100 years. I think that in regard to my specific program, we're very, very fortunate that we have to have a doctor on site because we're affiliated with an academic medical center with an active medical school. We have structured a program where all of the cardiology fellows rotate through as the supervising physician in our department. And these doctors are exposed to what cardiac rehab does. Once they are moving on and get their own practice, they, you know, start referring, they embrace cardiac rehab now, whereas it's not just thought of as a, you know, playtime, fun little thing to do. It's actually meaningful to them. And the patients, I mean, they have the luxury of having a doctor here, and the doctors just, you know, enjoy working with the patients. The other thing that is specific to our program is that because we're in a full service fitness facility, we utilize all of the weight training equipment. And because we have a lot of younger people that maybe have valves and gentlemen that have been exercisers, and we're able to provide them with a pretty appropriate major muscle group weight training basic program that they incorporate after maybe cardio assessment of their cardiovascular response for several weeks. I think that they like that. And even people, you know, housewives that have never done weights before, they really appreciate this strength training program that we're able to provide.
Does your cardiac rehab have a glucometer on site that you use on diabetic patients who may be symptomatic? And what model of glucometer do you use? And how do you get around having to quality check your glucometer daily if you are not open 7 days a week?
We have a glucometer that has been approved by our hospital, and it's a Contour because we can use it both for peritoneal and renal dialysis patients. It is a portable one. We're the only functioning department that has not tied into the lab itself, but we do biannual controls through our lab. We do controls daily that we are in operation, and that is how our policy is stated. We continue doing our glucometer, but we have the patient bring their glucometer in on first visits, make sure that they're using it properly, using needles, how do they do it, and how a little bit of education there. But from then on, we ask them to do a fasting at home. We do a pre and peak, our post blood sugar on all of our insulin dependent patients, and our facility is allowing us to do so with glucose tabs, strips. And then if they are on oral medication only, we take them times 6 for the first couple of visits, and then alternating it if there's any symptomatic or if there's any changes in their medication.
Yeah, I don't think it should be that much of a problem for not QCing a glucometer on days that you're not in operation. I think any accrediting agency would recognize that, and I don't think that should be an issue for any programs to have.
This is
Excellent.
Rita, and our facility allows us to do the exact same in regard to being tied into the hospital system as Barbara described. We're tied in, but our results are diverted, so they are not associated with a charge, and we're QCing just on the days of operation.
Great, thank you. So the next section we'll address is peripheral artery disease programming. This first has a few questions. So how do facilities plan to incorporate a peripheral artery disease supervised exercise therapy program in their cardiac rehab gym. Are most programs opting to have the PAD patients come during phase 2 class times, or will most programs be looking to have a separately scheduled supervised exercise therapy class for PAD patients? So this is for Jeff, Rita, and any other volunteers.
We're part of the HF Action Study where we had, some of those PAD patients coming to our department. We used to have a track in our facility, a mile track, which was very, very perfect for a lot of these things related to PAD. And we also participated or supported many research projects for PAD through our department, but it was sort of like a secondary type relationship. So we had, we have a PAD doctor that was very active in this, and her research associates would come and kind of run those programs in our department on days when we weren't there. Now, I've kind of reached out to some of those folks to see if they want to set up their own. Cost may be a problem for them to come through our department. I don't know, but I'm not sure whether we will assume that because we do have a department that kind of also treats specifically PAD patients, so we're kind of in limbo at this point.
And our programs right now starting to plan and try to decide how they're going to incorporate the PAD programs?
What I've been doing, though, is looking at the cost versus what we can do right now. And I've just basically created your self-paying program for your PADs right now with underneath their guidance of their vascular surgeons, cardiovascular surgeons. As well as I like to make a mention that if there is anyone that wants to start up this program, there is a PAD toolkit that's on the AACVPR website.
I also want to say, for our PAD program, we're going to do it on Tuesdays and Thursdays. We have the unique thing, in our program, we have phase 3 every afternoon. So we're going to incorporate in our phase 3, just because on Tuesdays and Thursdays we have less numbers in the afternoon. We'll be able to incorporate that a little bit more if it's just single PAD. Obviously, with other comorbidities, it would be in our other cardiac rehab for other diagnosis, but we'd still do a PAD program with them. Also want to join the fact too, if everybody remembers from the ISCHR annual conference, the Clever trial presentation.
Right.
I use that for our PAD protocol. I use their worksheet. If anybody wants to email me a question about it, I can send it to them. But that is what I use. Basically, it's you try to get them up to 2 miles an hour. Some of them might not get there, so you just keep going till they get, and you go to a pain of 3 to 4. Once you hit 4, they stop, or 8 minutes, whichever one comes first. And then they rest till it subsides, and then they go again. Same thing, get to a pain of 3 to 4, or 8 minutes, whichever comes first. If they get to 8 minutes, we increase the speed a little bit. If they get to 2 miles an hour, then once they get to 8 minutes, 2 miles an hour, then we increase the incline based on their protocol. There's also a home exercise guide for the PAD patients as well.
Planning on trying to implement these cases into our cardiac rehab program, because I think really the risk factor education is very similar. Now, one thing I will caution people on, if you are doing the exercise protocols according to the Clever trial, which has been shown to be effective in reducing symptoms, it is somewhat labor intensive. So I know that sometimes we like to kind of pack like patients in together, but keep in mind that, you know, when these patients start and you're encouraging them to exercise to that point of discomfort, it's a challenge from a labor standpoint. So, you know, if you're putting in, you know, say 7 or 8 patients at a time, you know, you're really going to kind of have to have enough staff on hand. I'm going with the strategy of kind of dividing those cases up a little bit so that there's maybe 2 or 3 per group, so that, you know, one staff member can work with those.
Great. So it sounds like if you wanted to see multiple PAD patients, it might make sense to do the Tuesday, Thursday sessions when phase 2 is not going on, as Jeff recommended. And yes, if you plan on doing it for phase 2, it might make a lot of sense to have fewer numbers of PAD patients. Excellent. Thank you for your input. The next question, would you use the same medical director to supervise and sign charts? This is for Jeff.
Would it be okay to have the same medical director?
I imagine it would be, because if the title of our department is cardiovascular. So if you're embracing all of that, I mean, certainly, and some of I like the fact that you mentioned the risk factors are very similar. There's a lot related to education and behavioral lifestyle that goes into, therapies toward both of, heart and vascular disease. I think it would be okay.
Okay, yeah, and our plan is basically to keep the same person, basically because we're doing Tuesday and Thursday, and our medical director is there Tuesdays and Thursdays as well, and he's there all day, so.
Okay, we'll move on to phase 1 cardiac rehab questions. The next one will be for Jim and any other volunteer. Does your facility have or still have a phase 1 cardiac rehab? If so, what kind of staff are you utilizing to staff it? Are they RNs, EPs? If you don't have a phase 1, how do you get the referrals to your phase 2 cardiac rehab program?
Okay, I'll answer this and say that yes, we have a very robust phase 1 cardiac rehabilitation. I have 2 FTEs associated to this per day. One person who is in it full time, and then the rest of my staff members, they all take a turn. And all my staff members, regardless of the disciplinary that they come from, is cross-trained in phase 1. So I have clinical exercise physiologists doing it, I have RNs, and I have RTs. And I thought the question was, it says, does every facility still have? And my thoughts on this are that really, I really believe that you have to have this. Now, when I took over this role at my current organization, they had started to phase out cardiac rehab phase 1, and I thought that was interesting. So I did a lot of analysis of it, and what I found is that when we were depending on our nursing staff on the inpatient side, to do the ambulation and the education, it just was not being done at the appropriate frequency or effectively. Then I also found that if we had cases where we had patients that somehow managed to slip through and not get inpatient cardiac rehab, there was almost a 0 chance that they were to follow up in our outpatient clinic. So I would say that I think, if you're a cardiac service line, I do think that some resources really have to be directed towards a phase 1 cardiac rehab in order to, give the patients that continuum of care that they really deserve.
Completely agree, Jim. Thank you very much. Is there anyone that would like to add to that?
This is Rita again, and we do not have a phase 1 that is staffed by cardiac rehab personnel. Surgical patients are seen by physical therapy. They have been introduced to referrals to phase 2. They have a brochure, pamphlet, and in invasive areas and inpatient heart failure floors, the nurses are relied upon to share this information, and then certainly our cardiologists are extremely supportive, so that's helpful. But I just wonder how many of you actually do have a phase 1 visit to inpatients that exercise your patients.
We don't have exercise for our phase 1s, unfortunately. I know other programs, just as Rita mentioned, have PT, and I see a lot of people go into that. Ours is just education, where we tell them after they have a procedure, we go on where they're in a EMR. Basically, we have a consult list for CHF and a consult for MIs and CABG, and we go see those patients and inform them about the cardiac rehab program, and then follow up with their. What's
I hear
that?
that a lot. I hear that a lot, that that's the way it's going, strictly kind of as a bridge
Yep.
to outpatient therapy.
Jeff, does your program have any FTEs dedicated to that phase one, though?
Unfortunately, no. We have someone for keeping track of the MIs for recording, purposes for the cardiovascular for certification. But we have no staff nurse for just make sure that phase one. They used to start out with that, and then they moved to phase two before they had phase two there. But currently they have not started that back up yet.
And I'm assuming you do track the number of patients you do see, since you don't have any allocated FTEs for phase one. You track to be able to report in some capacity.
We're supposed to. I'm not sure how they are tracking it. One of our nurses does most of the as a navigator for us.
Right. I was just wondering how that productivity was counted or credited to you guys, if it was.
We record them. I'm not sure what the tally is or how they're tallying them.
Okay.
But we do go see them, and then we have a tally for them. We should actually, that's one of the quality improvements I think we need to work on, is tracking them more. So.
Gotcha.
Thank you. The next question for phase one, this is for Barb and Eric. What are your physical requirements for phase one rehab? Do you need exercise or any physical evaluation, or can you do just education?
This is Barb. I have a very active surgery and PCI chest pain at my hospital. So what we've actually done is utilize my EP to go up on the floor with PT and do an evaluation at least one of their sessions in the afternoon, so that I can free my staff up enough to allow that one person to go up. So they would do, maybe the PT would do the ambulation part, or my EP would assist them. And while they're doing that, they're doing education at the same time. Recently, we've gone with Action Registry, which is the PCI registry, and it requires the phase one to be noted at the prior to discharge, as well as a referral to phase two prior to discharge. So we're trying to accomplish that intervention.
So my experience, our program here, we're still just a small program, just getting started. It's only myself and one FTE dedicated to an RN. Right now, it's just strictly education and phase two referral. We coordinate closely with the cath lab regarding their procedures for the week, and just make every effort to touch base with the patients who receive interventions to help facilitate that referral process and deliver education on CVD risk factors. We also work with case management to identify patients with a history of cardiovascular disease that may benefit from cardiac rehab services that are actual inpatients as well. It's been a little bit of a struggle with only two of us. That implementing that phase one process has been tough, especially since, as we just discussed, that there is no actual reimbursement for phase one services. So it is a little bit challenging in trying to, unfortunately, I was probably on the, 6 months ago, I would have been, questioned the, how necessarily useful phase one would be. But now I'm learning sort of maybe even the hard way that without phase one and an advocate from cardiac rehab, well educated and well versed in the benefits associated with cardiac rehab, to get that to navigate those patients and facilitate that referral process to the outpatient program. So I do think our volumes are suffering from that early on. So.
Sure. Great points. So we'll now naturally go into phase two related questions. This is a question that will be for the group and whoever would like to answer. Do you have a database that contains patient exercise session data and outcomes? Do you use these measures to evaluate your program design? And if so, what are the thresholds you look for to rethink your design?
This is Barb. We basically use our data sessions and outcomes based upon the registry. My cardiac rehab program is in the registry, ACVPRs, and then I've created a product right now for my pulmonary, since we're just starting it out. And with the outcomes, be aware that when you do your certification, they ask for these measures, and if you do the registry, you can pull them right up.
And so what do you look for within your database to decide if you need to change your program's design?
Actually, the outcomes based upon how are they fulfilling the need of dietary, blood pressure responses that we based upon our summary sheets that we come out with. We have the Cardiac Science QTEL system. So we can actually print out summaries per month to patients and say, hey, this is how your weight has been going, this is how your blood pressure has been going, this is how your heart rate going. To kind of give them feedback on how they're doing progression along.
We do something similar. We look for, our medical director is big into the weight, not gaining as much more weight. They should want to lose a couple pounds. That is one outcome we look at, as well as the outcomes, the depression outcome and quality of life. The one I do mostly with is that I gauge for our patients is those performance measures for functional capacity. 6-minute walk test is one where I do something a little different. I actually have a database, and I have different things I look at. I look at their heart rate, blood pressure at post-exercise. I also look at their RPP. And then I also look at, there's a calculation of VO2 peak, and then I also look to see how much their heart is working. That's I got this from the Canadian Physiology Association, where they do a ratio of what your heart rate is per minute of walking or per distance of walking, and it gives a ratio. And what I take with that, I don't necessarily give the numbers, but I can tell my patients then from that when they do it, oh, okay, why did I do this? Well, let me show you. And then I tell them about their functional capacity, how to increase, what's significant. And then I also tell them, you don't have to look at these numbers, but I can tell you if you look at how much bigger or smaller it is, your heart didn't have to work as much, which means your heart became more efficient. So that's something I can gauge how effective we did from a 6-minute walk test perspective.
Excellent, thank you. So the next question, does your program track patient progress and/or compliance to exercise after they complete a phase 2 cardiac rehab program? So whether they go on to phase 3 or if they decide not to and they decide to exercise on their own.
This is Rita, and I will say a question I'd like to add for the next roundtable, because I think this is actually extremely wonderful and productive here, but is if there's anyone that, and Barb may have come across it, a place where you can just enter data one place and be able to initiate progress reports for physicians, outcomes data, and follow-up without having to enter into more than one database. But we're still using the archaic Orions for outcomes, and they do automatically allow you to send a 6-month and 1-year follow-up questionnaire, and we do send them and calculate the information that is returned.
Piggybacking off that question, how many of you that use the registry actually utilize the follow-up portion to input follow-up data in the registry? Barb, do you guys use that, or just the pre and post program data?
Not at this time because of the time component.
Right. Okay.
This is for Jim and Eric. What are unique ways your program encourages exercise adoption on non-cardiac rehab days?
We visit this topic each and every session that a patient does come to, where we ask them, how many minutes of exercise are you doing? Did you do the day before? And I think it's been great, because then we can encourage them. If they're telling us that they're not doing any, well, there's a great opportunity. Okay, I'm going to have to find some time to get in a walk, go for a bike ride. Trying to teach them what is actually considered to be appropriate for exercise, because patients will tell us, I walk to the mailbox to get my mail. You hear all sorts of things where people, they try to rationalize their inactivity. So it's a great, I find that it's a great way for us to kind of encourage them to do more exercise on their days off. and then teaching them really what is an appropriate activity for them to be doing to count for this. Things that they're doing in their regular day-to-day activities, that's not what we mean. We mean, did you purposely go for a walk? Did you purposely go for a bike ride? Did you get on your elliptical? And we find that, that does tend to help encourage exercise on the off days.
Yeah, similar to Jim's response. Yeah, we do the same thing. In addition to every single session, asking patients, if they taken all their medications, if they had any changes in their medications. One of the questions we also ask at the beginning of every session is, what and how much exercise have you done since the last time you had a cardiac rehab session with us? And we document that response, and that's a great opportunity to provide some education if they're continuously giving you responses of, some of those half-baked responses or rationalized responses or just straight up telling you nothing. My answer directly to this question, though, and I wouldn't necessarily call it unique to our program, but we encourage patients to get involved by finding and engaging in community activities. If it's one thing I've learned is that the social aspect of exercise is increasingly important for people as they age. And I've noticed that the patients who report on follow-up that they're still exercising are doing so an overwhelming majority of the time in a social or group setting. So we always encourage patients. Still relatively new to the community I'm in now. I'm still learning what those social groups and opportunities are that are available in this area, but you just chatting with patients and learning what options there are in their community. A lot of times they know that, and then you just encourage them to kind of get involved with those and participate in those. So I found that's anytime I have a patient tell me that they're still exercising, a lot of times it's with others or doing other participating in groups or social settings. So.
Excellent. Yeah, I think we can all appreciate the importance of encouraging that home exercise because as patients get improvements from a cardiac rehab program, it's easy to revert back to that sedentary lifestyle and lose those improvements. So thank you. So the next question is related to has been a pretty hot topic in our field of the 10 plus years. Do you implement high intensity interval training? And if so, how do you decide which patients perform it? So this is for Jeff and Eric.
Jeff, you can go ahead. Sorry.
Okay, yeah. What we do is basically from the AACPR risk stratification, we go basically if they're low risk, and if they're moderate, they can move up into, and after a certain months, if we feel they're coming with no if they're asymptomatic, no active P, we can put them into, and they're well conditioned, we can put them into that high intensity interval training. When I first started this, I tried doing it with the speeds and the different changes, and I found with our population, most having just high school education, that wasn't going to work. And even now, sometimes it's hard for some people to follow. But what we did is I made a bar graph, and I made on a laminated card, and basically it says the bar graph from I make a 3-to-2 ratio or 4-to-2 ratio of work. So the 4 minutes they're at intensity of a grade, and then they come down to 0. It's not the best way to do it, but for simplicity for our patients to understand it, we started doing that where you do 3 or 4 minutes, depending on which card you get, at the incline. They'll make it more intense, and then you come back down to 0. And some of them might say, just come down to 2 or something, but the card says from incline, and then the next 2 minutes is 0 incline, and it's just a bar going up and down. That's how we incorporate high intensity interval training. That's how we choose who can do it.
And Jeff, so are you using heart rate data to decide how high that incline goes, or is it RPE based?
Depending on the patient, that's the other qualification as well. The also majority, unless I feel safe with them, they have to have a great exercise test with the beta blocker. And if they go RPE and there's no active P or anything, then yes, we'll go by RPE with the patient. And again, it's individually based on the patient, but typically they have a great exercise test. That way we know how high they can get with their beta blocker. And we can judge from that with those patients. Those who don't, we do use a heart rate reserve and we'll go anywhere. Just started with one patient where I said, okay, we can go up to who's a fireman trying to get back to work, who has not had any symptomatics or ectopy. We're going to start trying to incorporate that 90%, 80%. I haven't gone over 85, but I'm going to see what the 90%. Kind of wary on that, but going to see that with certain individuals.
So I don't often implement the high intensity interval training. I tend to really stick with the moderate intensity interval training. And in all honesty, I kind of reserve that for individuals who are, just like Jeff said, AACVPR risk stratified as low risk, and typically higher functioning to begin with. I think it's just a personal comfort level thing that I need to work through, because research is increasingly, as we all know, supports the use of MIT and HIT training in even higher risk patients. I also feel that, and Jeff did a great job. Jeff, I think, has some, in my opinion, sort of an innovative solution for this, but I feel that the HIT and MIT requires greater one-on-one level of education, training, and supervision of the patient. So it's a little bit more difficult to implement on a broader scale. But like I said, this could really just be a product of me not having a standard implementation process in place for those exercise protocols to deliver them in a broader scale. I like Jeff's solution of having the, laminated sort of placards and showing, visually with the bar graph, and having patients adjust their exercise. You can kind of just write over them, over those peaks and valleys of the bar graph, what intensity they need to be at. So it's a little bit easier to guide their exercise that way. We also have SciFit equipment here, and they have a program called FitKey software, which I've used before, where you just program the peaks and valleys, or the intervals, if you will, into the like a flash drive, and they plug it into the treadmill and then hit start, and it kind of adjusts it for them. That's been successful too, but once again, I think I definitely reserve it for patients that are lower risk and higher functioning, even though, as we know, the research is starting to come out and show that we can really utilize it more often and with higher risk patients.
Sure. And so after you identify a patient that may be eligible by your criteria to perform high-intensity interval training, is the next step to discuss whether or not they're interested, or is it, try this once and tell me what you think?
It's really try this once and tell me what you think. A lot of times we get really good feedback, because those individuals that are lower risk and higher functioning are looking to get a little bit more out of, I feel overall looking to get a little bit more out of the program anyway. They're asking, for more variation in what they do, and they want to be doing, to me, they seem to be going a little bit above and beyond, and those are the people I really try and implement the high intensity interval training with. So.
Excellent, thank you. Next question. This is for the group, whoever would like to volunteer. Does your program use phone apps or other technology to promote a healthy lifestyle? If so, does it work?
This is Barb. What I've been presently using is the American Heart Association Patient Network, and giving that app and giving that information to my patients, saying, hey, this is a 24-hour link. You can ask your question, and it will be given to you by professionals and not someone on Medscape or someone. And patients who want to use apps, they're very willing to use this app, and I can't think of anything better than that.
We use a stress management app. One of our nurses has an app that she uses, and we ask who is interested. After we tag team it right now, because our psych department is still rebuilding a little bit and being restructured. So we took over the stress management, and I do the education compartment, and then she does a meditation for 10 minutes, and she shows who's ever interested into an app for the meditation for stress management. And that's how we use our training group technology with our patients.
We are going to be rolling out a education system from one of the vendors that's going to, I really like it. It's going to allow us to kind of standardize the education for those people who want to take more home from their, the regular cardiac rehab classes. Everything related to heart failure care, to care after your MI. And we're going to be able to assign these to the patients, give them specific passwords and logins so that they can go at it at their own pace. So I'm very excited about that. I also really like to encourage patients to use their smartphones as far as just using the pedometers on their smartphones. It's already something that's being tracked, and I really like showing them how to use that. We've had some pretty good success with that.
Great. We're running short on time, so I think we have time for maybe one, maybe two questions. So this one, again, is for the group. How are different sites registering their patients into phase 2? Are you using a hospital-based registration admitting system? If so, how long does it take to get the patients from discharge to rehab?
I'm not quite clear on that. What we presently are using, we have the phase 1, we have surgery and the PCIs, again, at the hospital-based facility. So we get the phase 2 referral, get the referral in my hand, and usually about 2 to 3 weeks later, I can get them registered through our own scheduling module that I do after contacting the patient. We register them. They do have the component in it that every 30 days I have to re-register them. They're considered discharged from the program and then given another hospital number, and that's how we keep registering them.
We register through a computer EMR as well. We don't have to re-register them. They automatically come up with a different CAR or account number after each month. And the length of time to get them from discharge to rehab depends on a lot of variables. I mean, it only takes us, you know, once they call us or once we set them up, you know, verbally or discover that they're appropriate, et cetera. I mean, it takes a minute just to, you know, well, it takes 10 minutes to register them. And our department staff is doing that ourselves. I know that some of our sister facilities in the corporation do have dedicated administrative assistant people that are doing it, but in my particular department, since there's 4 FTEs, 6 individuals, we are all registering patients. We don't have an admin or secretarial or support type of person to do that paperwork. Anybody else?
Okay, well, I think that is all the time that we have today. There were still a number of questions that were submitted that we weren't able to get to. However, we're going to hold another education event to be able to address those. So this concludes our panel roundtable Q&A session. The ISCHR would like to thank the entire panelist group for joining us today and taking time out of their busy schedules. We also like to thank the ISCHR members who submitted questions for this panel roundtable Q&A. This session was recorded and will be available to ISCHR members on the ISCHR website. Another education event will be presented by the Education Committee in November. So please keep a lookout for that. And thank you very much for listening in. Have a great day.